less controversial and more of guidelines and complication in twin pregnancy. So my talk is based upon ISWA guideline of published in 2016 and another in 2007. So basically, the basic thing is amnioticity, chronicity, and zygosity. So when a zygote forms from a single egg fertilization and it divides, they are genetically similar and has shared placenta. So they are basically monochorionic, whereas when there are two zygotes, they actually divide and they have a separate placenta, so they are zygotic. So monochorionic, monoamniotic twins are always monozygotic, and opposite is not true. How? So basically, if you see that there are two embryos, so they actually give rise to the dichorionic diamniotic pregnancy. Whereas monozygotic twinning can give rise to the dizygotic dichorionic diamniotic twins, monochorionic diamniotic twins, and monochorionic monoamniotic twins divide. And it depends upon the time of division. So if it is within 72 hours, it gives rise to the DADC. If it is 4 to 8 days, then it is MCDA, and if it is more than 8 days, then it is monochorionic amniotic. So the basic thing is that chronicity is the number of placenta, amnioticity is the number of amniotic cavity, and zygosity is the twins from one or two embryos. So why determination of chronicity is so important? Because of the inherent complication. So if you see the complication of either miscarriage or the fetal anomalies or the perinatal mortality or preterm delivery or FGR or birth weight less than 5th centile in both twins, they are all more in the monochorionic pregnancy than the dichorionic pregnancy. So that is why it is important to diagnose it is as early as possible. So in early pregnancy, if we see a single sac with two embryo, then most likely it is monochorionic pregnancy. If we are seeing two different gestational sacs, they are most likely dichorionic pregnancy. If we are seeing a thin membrane between the two fetuses, then they are likely to be monochorionic diamniotic pregnancy. And if we are seeing two log sac in a single sac, then they are most likely to be diamniotic monochorionic pregnancy. But these are all just suspicion. They are not diagnostics. Dating of a pregnancy is done when the CRL is 45 millimeter to 84 millimeter, and in the cases of spontaneous conception, larger of the two CRL is used to estimate the gestational age, whereas in IVF cases, the oocyte retrieval date or the embryonic age from the fertilization is used for the dating purposes. But we must diagnose chronicity by 13 weeks, 6 days of gestation, because this is so important. They can be diagnosed either using the membrane thickness at the site of insertion of the amniotic membrane into the placenta. If it is more than 2 millimeter, it goes in favor of dichorionic, and if it is less than 2 millimeter, then it goes more in favor of the monochorionic. If then the T sign and the lambda sign, and if you are lucky, then you will see the two separate placenta, and then the diagnosis is easy. But mostly we see either the lambda sign or the T sign. But whenever you diagnose it either dichorionic or the monochorionic, the guideline says then an ultrasound image demonstrating the chronicity should be kept in the records for the future tests. So what is lambda and T sign? So in the dichorionic pregnancy, the placenta travels all the way to the midline. So there is a thicker membrane because there is not only the amnion, there is the chorion as well. So if the chorion goes from both the sides, it gives the sign of lambda. Whereas if there is an absence of chorion going to the midline, then it gives the sign of T here. So, but many times we falsely also see the lambda sign, like in this case. But if you are seeing it, so that is not taken as that of the DADC pregnancy. So sometimes even the best of efforts, we could not determine the amnioticity and permosity. So in that case, second opinion should be sought from a tertiary referral center if not determined in the routine setting. That's what guidelines says. And at the time at which chronicity is determined, amnioticity should also be determined and documented. MCMA twin, that is the monochorionic monoamniotic twin pregnancy, should be referred to a tertiary center with expertise in their management. That is what guideline says. If the center is uncertain about the chronicity, it is safer to classify the pregnancy as monochorionic, so that the center should be ready for those complications. And in cases of doubt, absence of intertwined membrane is best confirmed by the TVS scan. So if you are not seeing a membrane on the TAS, then you must do the TVS before saying that it is absent. Sometimes we see the cord entanglement, and it is actually universal in monochorionic monoamniotic twin pregnancy. So whenever it is present, then we can safely say that this is monochorionic monoamniotic pregnancy. And the first trimester, the time when we do the NT-NB scan, is the ideal time for the termination of the chronicity and amnioticity, because determination of chronicity is most accurate at the 11 to 14 week of gestation, when the amnion and chorion have not yet fused. So after 14 weeks, amnion and chorion fuse kar jata hai. At that time, it is difficult. How to label it, because many people write it like the right one or left one. So it is advisable to describe each twins using as many as features as possible, so as to enable others to identify them accurately. Suppose आपने right side और left side लिखा और वो patient कहीं और गया, उनका right side और left side फिर different होगा. इसलिए whenever you are describing a fetus, you should describe with as many as features possible. What the practice we follow in our day-to-day practice is the presenting fetus and the after coming fetus. So presenting fetus will never changes. It will be the same. Now the routine ultrasound monitoring of the pregnancies. So in the dichorionic pregnancy, it is almost that of the same what we see in our singleton pregnancy. That is, in our 11 to 14 weeks, we do the dating, labeling, chronicity, and screening for trisomy 21. In 20 to 22 weeks, we do the detailed anatomy, biometry, amniotic fluid volume, and cervical length. And afterwards, every 4 weeks. That is 24 to 26, 26 to 28, 32 to 34, 36 to 37, and delivery by 37 weeks. But in cases of monochorionic pregnancy, this monitoring should be more frequent and more specialized. How? So if you see that after your NT-NV scan, 11 to 14 weeks scan, before 20 weeks scan, we have two more scans. One is the 16 weeks scan and another is the 18 weeks scan for not only the deep vertical pocket diameter, rather than for the umbilical artery PI Doppler as well, just because the complications are much more common. And afterward, we are doing it for the every 2 weeks. And if you are seeing the 20 weeks scan as also, then in 20 weeks scan, we are adding here MCA PSV that is not there in the DC pregnancy. So this is slightly different. And in fact, afterward also in 20 weeks, 24 weeks, 26, 28 weeks pregnancy, we are adding MCA PSV also. So what to see in this twin pregnancy? We are seeing the fetal biometry, amniotic fluid volume, umbilical artery Doppler from 20 weeks gestation for both the twins, and discordance in estimated fetal weight. So discordance, it need not to be calculated. It is again in your machines, and if you see that your the ultrasound machine itself will calculate it for you. So when we are looking for the structure abnormalities in twin, we will first do the NT-NV scan and the routine second trimester scan. But we should also add fetal echo in the form of cardiac screening assessment in the monochorionic twins, because we know that the chances of cardiac defects is more in the monochorionic twins. And when we are doing our routine anomaly scan, it is slightly difficult because it takes more time because of the second, the fetus. An increase of incidence of anomalies is also higher in the monozygotic twins. That is around 2 to 3 times higher. So sonographic evaluation before 13 plus 6 weeks is very important in twins. As in singleton pregnancy, this examination can detect those twin fetuses at increased risk of the chromosomal abnormality. But further, it can detect the high risk group of the monochorionic twins that needs intensive counseling and monitoring. The timing is also, if we are seeing the twin pregnancies, then we can do it in slightly later gestational age than in the singleton pregnancy, because we know that many of the defects appear later. So we should know that brain and cardiac abnormality might become more obvious in the third trimester. So if you are doing a third trimester ultrasound in cases of twins, then you should be in aware that brain and cardiac abnormality should be looked for. So those defects, those are more common in the twins, are the neural tube defect, anterior abdominal wall defect, facial cleft, brain abnormalities, cardiac defect, and gastrointestinal. This work guideline says that we should do the routine cardiac assessment. That is, when we are doing our 18 to 20 weeks scan also, then we should include all the things of the ISWOG guidance. That is the laterality, situs, four-chamber view, for ventricular outflow tract, and everything else. And the most important thing, that it is important to make the women aware of the limitation of the ultrasound screening, which vary according to the type of anomaly. So we in our practice, we write in our report that the limitation of ultrasound in detection of congenital anomalies in twins has been explained to the patient and companion, because we know the chances of missing anomalies in these twins are much more than that of the singleton. So our detection rate falls down. If we are seeing concordance for a structure anomalies, then we should send the patient for a regional fetal medicine center for further management. And if we are seeing discordant anomalies are not so common, then expert ultrasound assessment in a tertiary center, invasive fetal chromosomal or genetic testing if indicated, and discussion of the likely prognosis for both the affected and normal twins are essential. So the guidelines has been made so that we can diagnose the complications and diagnose it early. So that is why these guidelines for ultrasound follow-up are meant to diagnose basically these complications early. How? So if you are seeing a cervical length assessment that is added in the 20 to 22 weeks scan in twins, then it is to diagnose the preterm birth, because cervical assessment measurement is a preferred method of screening for preterm birth in twins, and 25 millimeter is the cutoff for most commonly used in the second trimester. In asymptomatic women, a cervical length less than or equal to 20 millimeter at 20 to 24 weeks was the most accurate predictor of preterm birth before 32 to 34 weeks, but predictive accuracy of cervical length for preterm birth was low in the symptomatic women. Similarly, if we are seeing that we are doing it on every 2 weeks, then we need to check for the deepest vertical pocket diameter as well as bladder, urinary bladder. And MCA PSB we always see from 20 weeks onward in diagnose the TAPS. So the most common complication is the twin to twin transfusion, and that is why urinary bladder is said to be seen in ultrasound of twins each time, because it is present in 10 to 15% of the monochorionic pregnancies. Sometimes we just see and stuck twins. If you see this twins, so this is totally stuck to the placenta, and then we should started searching for the other features. Like if you see that in this fetus bladder is not seen, so now you know that this fetus is TTS actually, and this was the fetus that has been diagnosed as 16 week and other treated to be delivered as a normal twins lateral. So that is why diagnosis of TTS is very, very important, and it can be suspected as early as 11 to 14 weeks by the discordance in the size of the amniotic fluid sacs, more than 20% discordance in the fetal nuchal translucency thickness, and abnormal or reverse end diastolic flow in the ductus venosus, usually in the fetuses with higher NT. So if you are seeing 20% or more than 20% discordance in the fetal nuchal translucency thickness, then you must be aware that you might deal with TTS in these fetuses. More than 15 weeks, if you are seeing there is oligohydramnios, that is the deepest vertical pocket less than or equal to 2 centimeter, or poly, that is more than 6 centimeter at 15 to 17 weeks, more than 8 centimeter at 18 to 20 weeks, and more than 10 centimeter at 20 weeks in the recipient. So if after 15 weeks you are seeing that one baby is oligo and apart from different staging, the most reliable is the Quintero staging system. The stage 1 is when the poly-oligo-amino sequence happens. That is the deepest vertical pocket diameter less than 1 or 2 umbilical venous flow in either twins. Stage 4 is hydrops in one or both twins. And stage 5 is death of one or both twins. So if you are lucky and you are diagnosing it in stage 1, then the chances that you are saving 50% of this baby. That is why staging TTTS, diagnosing it early is very, very important. Prognosis for monochorionic twin pregnancy with amniotic fluid discordance. So if you are not seeing other things of TTTS, but if you are seeing just amniotic fluid discordance and which is not filling the 8 centimeter and 2 centimeter criteria, and if they have normal umbilical artery Doppler measurement, they are associated with good outcome. So if you are suspecting oligo and poly, but they are not meeting 8 centimeter and 2 centimeter criteria, you are doing the Doppler and Doppler is normal, then you can counsel that these fetuses have good prognosis, but it need follow-up on the weekly basis so that they should not develop other signs of disease. Management is laser ablation. Stage 1, it has 50% of the stage 2 and above. Conservative management with close surveillance and laser ablation can be considered for stage 1. When laser treatment is not there, serial amyloid reduction is an acceptable alternative after 26 weeks. How to do the follow-up? Weekly ultrasound for the first 2 weeks after treatment, reducing to alternate weeks following clinical evidence of resolution. In case of demise of one fetus post-laser, brain imaging of the surviving co-twins should be considered. 4 to 6 weeks lateral and neurodevelopmental assessment should take place at 2 years of age. Because if you have one fetus that has demise, then the chances of neurodevelopmental delay in the fetuses are there. So they have to be assessed at the age of 2 years post. Now, why we are looking for MCA PSV? MCA PSV is looking to diagnose TAP, that is twin anemia polycythemia sequence. So in which actually there is an abnormal vasculature. So one fetus is anemic and another is polycythemia. So how to diagnose it? So first you will see that the placenta is thick and hyperechoic in anemic fetuses, and it is thin and translucent in the polycythemic fetus. But the hallmark is MCA PSV. That is why the guideline has included MCA PSV. Because if you are seeing that more than 1.5 mom MCA PSV, then they are anemic fetuses, and if it is less than 1 mom, then they are polycythemic. So you must do MCA PSV Doppler in every monochorionic pregnancy. Each time they will visit you after 20. Anemic fetuses has a dilated heart and tricuspid regurgitation and the ascites. Sometimes we see there is a starry sky pattern of the liver, where you will see a black liver, hypoechoic liver, with increased brightness of the portal venule valve, like in this case. When we are diagnosing TAP sequence, then we should also look for the detailed ultrasound examination, echocardiography to assess the cardiac function and measurement of PSV regularly. Chances of chromosomal abnormality, genetic syndromes are not increased in these fetuses. Management is individualized, conservative management and early delivery, laser ablation, IUT and combined IUT for the anemic twin, and partial exchange transfusion to dilute the blood of the polycythemic twins. Another is complication is our twin arterial perfusion syndrome. So in this case, actually there is one acardiac twin that is that has a rudimentary heart. So it actually leads to the another normal fetus that is pump twin. They started to pump and finally their heart fails. So they are diagnosed by a variable degree of deficient development of head and upper limbs and hydrops in the recipient twin. Like in this case, if you are seeing increased NT with another acardiac twin, then slowly we'll see cystic hygroma and all the changes of hydrops. But the most important is the Doppler, when we see the reverse pulsatile flow from an umbilical arterial anastomosis and venous return to the pumping via the venous anastomosis. Part of acardiac twin arises directly from that of the pump twins. There are chances of other defects like encephalic gastrocytosis, renal and skeletal abnormalities with these complications, and they are managed by the minimally invasive techniques. Another thing is we should always see for the effective fetal weight discordance. This guideline suggests to see it from 20 weeks onward, just to diagnose your selective fetal growth restriction. So here our criteria is different, because selective fetal growth restriction conventionally is defined as a condition in which one fetus has effective fetal weight less than 10 centile and inter-twin effective fetal discordance is more than 25%. But its WOG guideline authors bring them down to 20% to it's more acceptable to distinguish pregnancy at increased risk of the adverse outcome. So first thing we need to do in these fetuses is the detailed anomaly scan and screening for the viral infections, and then if needed amniocentesis also. So they are classified according to the umbilical artery flow into type 1, which is having normal end diastolic flow, type 2 having absent or the reverse end diastolic flow, and type 3 is having intermittent, absent or reverse end diastolic flow. Type 3 has got good prognosis, whereas type 3 has got poor prognosis. Follow-up in dichorionic and monochorionic fetal Doppler should be assessed approximately every 2 weeks and weekly respectively, depending upon the severity. If there is substantial risk of fetal demise of one protein before 26 weeks, selective termination may be considered. And if you are seeing more than 25% of the discordance, then there might be selective fetal growth restriction with superimposed DTS. Another is the less common complication is monoamniotic twins, where there is an absence of inter twin membrane. Here we see the cord entanglement and the presence of an umbilical artery notch also, which is not indicative of an adverse perinatal outcome. But here, cesarean section is advised at 32 to 34 weeks. Conjoined conjoined twins can be diagnosed as early as 9 weeks, in most cases before mid-trimester scan. Whenever we are seeing structural abnormalities, and if there is a lethal abnormality, best to avoid the risk associated with selective feticide unless the condition itself threatens the survival of the normal twin. If you are seeing an cephalic in one twin and another twin is normal, then we should not better go for the selective feticide rather than we should wait, because there are already risks associated with this selective feticide. And how to manage the surviving twins after the demise of its coitus. when there is a single IUD occurs in twin pregnancy, the woman should be referred to a tertiary level center with the relevant expertise only. Because if there is a death of co-twin, that is there in 15% of cases of monochorionic and 3% of cases of the dichorionic, then the chances of preterm delivery is 68%, is more in again monochorionic twins. Absence, abnormal postnatal cranial imaging of co-twins is also more, and plus neurodevelopmental impairment of the surviving co-twins is also there. That is why you should assess this fetuses again at 2 years of age to see that what kind of neurodevelopmental impairment they have. So this was a long talk, and the take-home messages is small. That ultrasound monitoring in twins should follow his WALK guideline for early detection of complication. And believe me, chronicity determines the prognosis of twin pregnancy. So always diagnose it whenever it is not there in the ultrasound report in your 11 to 13 weeks scan. Ask for it, demand for it. Thank you so much for all your attention. Mute है मैम, मैम म्यूट है, राधा मैम म्यूट है,
मैम आवाज नहीं आ रही।
मैम म्यूट है।
Yes. I will see to it that recording of this, both the presentation will be sent to, will be shared on a respective forums WhatsApp group. I will ask Dr. Achala Batra to just repeat the take-home messages for the gynecologists, because now the twin management has not remained the same as our earlier days. Dr. Achala Batra.
Thank you, ma'am. Actually, from the time we have been studying, we've always been told when you diagnose the twin, unless you mention the chorionicity, the diagnosis is incomplete, because there is a difference in complications between monochorionic and dichorionic. And now with so much advance in the ultrasound, we know that monochorionic have to be monitored repeatedly from 16 week onward for the development of twin transfusions. And even dichorionic, for the growth of the fetus, we have to monitor them by ultrasound. Clinically, it is just not possible. So it is comes as a very good the management of twin pregnancies, the ultrasound, and we really need the help of the good ultrasonologists in the management of a twin pregnancy.
And right in the beginning, it should be written down on the file that this kind of frequent monitoring it will be required. Dr. Mamta Mittal is here. Dr. Seema Sehgal is here. So we will take last word from Dr. Jyoti Bhaskar. Dr. Jyoti Bhaskar, you've contributed a chapter on multiple pregnancy. So let's hear from you. The take-home messages.
Madam, it's a very extensive talk that Dr. Krishna Gopal gave us, and with a lot of messages, a lot of important things. But as a gynecologist, the main thing that Dr. Achala also said, and everyone, please look for the chorionicity, because that tends to determine how we're going to manage this patient. Second is, how do we monitor these patients once they have reached about 16? So if it's a monochorionic twin from 16 weeks onwards, please refer the patient to get her ultrasound monitoring done every 2 weeks. And for a dichorionic twin from 20 weeks, we need them to be monitored by ultrasound every 4 weeks. And the decision has to be taken based upon these particular growth assessments that we do. While monochorionic, we need to consider a decision between 35 weeks or earlier if the fetal parameters are haywire. While a dichorionic twin, everything is going fine, we can easily take them to 37 weeks of pregnancy. So main emphasis is on monitoring, and we need to explain this and counsel it to the patient that if we need a good outcome, it has to be regularly monitored both clinically as well as by ultrasound.
I think it has been wonderful. Yes, Dr. Poonam.
In centers like us, if we have any maybe mono or maybe dichorionic, I always tell the patient to have one registration at higher center also.
Here I just wish to tell you is that, you all people are lucky that you are working in Delhi, and Fetal Medicine Department of All India Institute is always ready 24 hours for your patients' help. So I will post the number of Madam Archana from All India Institute of Medical Sciences, and that number should be ready with you. And I will also post you the summary of Dr. Krishna Gopal presentation. It had been absolutely a treat, and to inputs of all experts has been absolutely great. Absolutely great. Thank you very much, everybody. Dr. Gopal, this is a small token of ours, for being a great teacher for all of us. Congratulations to you.
Thank you, all of you.
Thank you very much. Thank you very much.
Thank you very much.
Dr. Dipti is kind enough to give you 2 certificates. Thank you very much. Thank you very much.
Thank you for the certificate.
Thank you.
Thank you.
Thank you, Dr. Gopal, so much. Thank you, Dr. Achala Batra.
Stay safe. All of you stay safe.
Yes,
That is so important.
yes, everybody, all of you, life is very important. Please play very, very safe. Thank you very much.
Thank you,
Thank you, everybody. Thank you.
Thank you, everybody.
Thank you.
Thank you, everybody.